A 20 years male presented with corneal opacity and visual loss in the left eye for 4 years. He was operated for traumatic cataract 8 years back. On examination, vision, hand movement, corneal haze with epithelial hypertrophy, edema. Anterior chamber barely visible, query IOL haptic in the anterior chamber. Planned for penetrating keratoplasty because of apparent long-standing corneal scarring. But surprisingly, the hypertrophic epithelium could be easily peeled off and the AC was visible with decentered IOL with one haptic in anterior chamber. Operative plan was changed to dissect with IOL repositioning. Note the movement of the haptic in AC and intermittent touch with the cornea. Under cohesive viscoelastics, the IOL haptic was placed into the sulcus. Then the IOL was centered with the help of Sinski's hook. Intracameral pilocarpine to constrict the pupil. After Descemet stripping of the recipient, donor posterior lamellar tissue was gently introduced into the anterior chamber. Donor unfolding with the help of air, then centering. Part of the ear was replaced by BSS. After 7 days, the patient was fine, cornea relatively clear, IOL centered and vision 20/100. But a big surprise at second week. IOL again displaced inferiorly with one haptic in the anterior chamber. Donor button was well attached, cornea clear with a good endothelial cell count. Now the question is, what next? Only 2 weeks post-operative dissect, IOL exchange or any other option. Decision was taken to exchange the IOL with larger diameter PMMA IOL. Side port incisions opened, AC filled with cohesive viscoelastics. Previous tunnel was opened and enlarged to 6.5 mm. IOL was then uplifted into the AC and carefully the upper haptic was taken out of the wound. Then the IOL was removed from the eye. Note that the previous IOL was smaller in size. Now more viscoelastic to make the AC deeper. A new 6.5 and 13.5 mm single piece PMMA IOL was then implanted into the sulcus. AC formed with BSS. 1 month after the second surgery, see the cornea is absolutely clear, BCV at 20/40 with a good endothelial cell count. IOL is now centered and the patient is happy with a hassle-free life. We had similar examples with other patients and treated by dissect with IOL repositioning. Surgical and visual outcomes were good. One haptic of PCIOL in AC and hassles always go together. The endothelial cell count is always on the lower side because of haptic rubs against endothelium resulting in corneal decompensation. So the take-home message, whenever you encounter such a case of one haptic of PCIOL in AC, just dial it and push the haptic back into the posterior chamber and relax. Thank you very much for your kind attention.